Welcome, everyone. Thank you so much for joining. We'll get started here in just a second. I'm going to let everyone get into the room. If by chance your name is showing as Ashley Locke, if you could just quickly rename yourselves, that would be great. Otherwise, you'll show up as myself throughout the meeting. All right, we're going to go ahead and get started. Well, I want to welcome everyone to the first session of the 2026 Rural Learning Community on behalf of the American Cancer Society and the American Cancer Society's National HPV Vaccination Roundtable. Thank you for joining us. So this year, we're going to spend the next 8 months working together to strengthen rural strategies, share promising practices, and boost both HPV vaccination rates and access to cancer screenings across rural communities. With 57 million people living in rural America, the need and the opportunity for impact is tremendous. We're excited to learn, collaborate, and make progress with all of you. I do want to note that this program is supported by a grant from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. If you want to go to the next slide. So, for those that are just joining and haven't met me before, I'm Ashley Locke. I'm a program manager for knowledge translation at the American Cancer Society. I have the privilege of leading the rural learning community and want to acknowledge that this work is truly a team effort. I'm a part of an incredible group of colleagues across both the American Cancer Society and the National HPV Vaccination Roundtable who are dedicated to increasing HPV vaccinations, expanding access to cancer screenings, and supporting rural communities every day. If you want to go to the next slide. So, as always, we like to start our rural sessions with a quick icebreaker. And since today marks the kickoff of our 2026 Rural Learning Community and our first session focused on cancer screening in rural communities, we'd love to hear from all of you. So, our question is, what excites you most about the growing role of self-collection in cervical cancer screening? So go ahead and feel free to share your thoughts in the chat, whether that's expanding access, reducing barriers, or reaching more people in rural communities. Your perspective really will help ground today's conversation. So go ahead and add those to the chat. And while you're doing so, I am going to quickly review our agenda and learning objectives, and then I'll come back and read a few of them to you all. So if you want to go to the next slide, Hannah. Perfect. So to give you a quick overview of today's session, here's what we have planned. So we're currently talking through our welcome and logistics. Next, we're going to hear a powerful cancer survivor spotlight from Ginny Marble, a survivor ambassador who will help ground us in this real world impact of the work. Then we're going to move into a didactic session, which is an update on the American Cancer Society cervical cancer screening guidelines, presented by Dr. Deanna Baptiste. And after that, we're going to transition into a panel discussion where we're going to feature Deanna, Dr. Carolyn Halley, Dr. Gary Pugh, and Dr. Lisa Soltani, who will share insights and experiences from their clinical and community work. And then finally, we're going to wrap up with some resources and next steps to support you beyond today's session. Just a couple of reminders. Today's session is being recorded and will be posted to a publicly facing website. We are providing live CME and CNE credits, and we're going to share some more information about that in the chat, and as well as in our learning materials library. But none of the planners or panelists or didactic speakers have anything to disclose today. This meeting is meant to be interactive. However, we ask that you stay muted during our presentations, but we invite you to use the chat throughout the session to answer for questions and comments. And then if you want to go to the next slide. So this slide reviews our learning objectives for today's session. So we're going to focus on how to educate patients on the current cervical cancer screening guidelines. And then we're going to also explore practical strategies to integrate self-collection screening programs into rural clinical and community settings. So these objectives really are going to guide our conversation and help ensure you leave with information and tools that you can apply right away. And then if you want to go to the next slide. We are going to do a quick poll. to get a sense of who's in the room today and you're familiar with today's topic. You'll see a few questions pop up about your knowledge of the American Cancer Society cervical cancer screening guidelines, your familiarity with a cervical cancer self-collection, and whether your organization is currently implementing self-collection. So go ahead and answer that poll quickly. And then while you do so, I'm going to just highlight a few things that were shared in the chat from our icebreaker. So I see some are excited about how self-collection will reduce barriers to those who might have barriers. So that's very exciting. Increasing early cervical cancer detection for those who would not be tested. Very exciting as well. Increasing access and decreasing stigma. Learning more about self-collection and screening events. Reaching patients who may not be able to be reached otherwise. That's very exciting. Pam Mason shared expanding access. Just interested in learning more. That's great too. The impact it can make in frontier and rural communities. I'm seeing a lot of access, which is very exciting. Well, thank you all for participating in the poll. We can go ahead and stop that and then move to the next slide. Perfect. So I am happy to now transition to our survivor highlight. I'd like to introduce Ginny Marable, who is a survivor ambassador. Ginny's full bio will be added to the chat as well as a way to connect with her.
Greetings. It is an honor to be here today to share my cervical cancer story with all of you. Before I dive into that, I just want to acknowledge and thank each and every one of you for being here. Your commitment to ending cervical cancer is what is truly energizing to someone who has survived it. So I appreciate you taking the time to learn about the latest and greatest, and I am truly honored to be able to share my story with all of you today. So a little bit about myself. We can go to the next one more slide. A little bit about myself. One more slide. Next slide. Um, is here. So on the top left, this is my version of a modern family, and I'll share a little bit more about that. But next to me is Tamika Felder, who is the founder of Survivor with a C, the cervical cancer organization that I'm a part of. And she's also the chief visionary and a dear friend, and I'll tell you more about our connection later. One of my personal philosophies is kindness is a superpower. And I try to embed kindness in everything that I do, particularly in being a mom to Grant and Emmett, my darling twin boys that are pictured here. They turn 5 next week, and it's just such a fun age. They're the light of my life. On the bottom left is my Survivor sisters. So every year, Survivor hosts what they call a Survivor School. During that 3-day interactive event, survivors are equipped to tell their stories. We have panels and experts come in to make sure that we're not only just able to equip to tell our story, but to be able to equip to tell it with facts and the latest and greatest medical data. And self-collection has been a theme over the last few years. And I've had the opportunity to connect with so many other cervical cancer survivors across the globe, truly through this organization. The work is really impactful. So I appreciate all of American Cancer Society's support of what we do there too. I am 8 years cancer free, but I want to back up and talk a little bit about my journey to get there. So we'll go to the next slide and I'll walk through my timeline. So this section was titled "It All Started with a Pair of UGG Sweatpants" because that's truly what it did. That's when I first started noticing that something was wrong, and I first started noticing one of the most common symptoms of cervical cancer, which is I was experiencing early, or I was experiencing clear leakage or discharge in my panties on a regular basis. As a result, I was denying myself the simple luxury of wearing these luxurious UGG fleece-lined sweatpants that my boyfriend, now husband, had gifted me for Christmas in 2015. They required, a gentle cycle and being hand uh, or air dried and hung dry. And that was just way too much effort. When I was denying myself this basic, simple luxury, I knew something was really wrong. And that's when I decided to call my doctor. I called my primary care physician and got in just January or February of 2016. So pretty quickly, from when I started noticing symptoms, I went into the doctor's office and she was quick to diagnose me with an overactive bladder that could be resolved through just doing Kegels. She said, you're 30 years old, just do Kegels and this will resolve itself. I was really not satisfied with that answer, and I knew something was wrong, but she reluctantly referred me to a urologist. I went home from the doctor's office that day and I was in tears. My husband found me curled up on our guest bedroom, uh, and he was like, "What's wrong?" And I'm like, I went to the doctor and she really brushed me off. She didn't believe me. And yeah, I still remember that day of like, gosh, like I was, it, yeah, it was really impactful. So I went about getting treated for an overactive bladder for almost 12 months. Um, a little over 12 months. Of course, it took a couple months to get in to a specialist and then was treated for that. My symptoms didn't improve, they only got worse. So I decided to go see a gynecological urologist who then recognized that something was maybe more seriously wrong, who then referred me to a gynecologist. The gynecologist did a pap smear. She recognized that my cervix was completely hard, and on the spot in her office that day, she did a colposcopy. Um, my husband and I had already had a pre-planned vacation planned, so she waited to call me with the results until I got back. And on April 3rd, 2017, she called me with the news that I had cervical cancer. Um, I was devastated, of course. I uh, quickly found out that that would mean that I could possibly lose my fertility as well. I had, I was just about to turn 31 when I was diagnosed, and my husband and I were pretty serious. We were just dating at the time, but he and I both knew we both wanted to be parents one day. And that hope and dream really got crushed in a moment with that update. Um, Fortunately, my oncologist allowed me to go through IVF, fertility preserving treatment prior to really launching treatment into cervical cancer or for treating the cervical cancer. So I was able to complete one round of IVF, which resulted in 5 healthy embryos. And that was sort of our insurance plan for down the road for creating our family. In May of 2017, I started treatment. It was initially supposed to be just surgical, and then they went in and discovered the tumor was about twice the size that they initially thought from the MRI. They thought it was 2 to 3 centimeters. It ended up being 6 centimeter tumor growing on my cervix. Between May and August of 2017, I went through 30 rounds of radiation, 6 rounds of chemo, and 4 different surgeries to eventually become cancer-free in August 2017. The work was so far from over in August of 2017. I remember everyone around me was celebrating, and I was just like, I am so devastated about everything that I had lost. And that's when the healing really began. So, over the next 3 years, I conducted, I got married, took charge of my health. I, I started doing this kind of more holistic approach to my health. And I was still experiencing some pretty serious side effects of radiation where I was experiencing vaginal stenosis, where my vagina basically had glued back together. So in July of 2020, I finally had my last surgery. So here's me coming out of the OHSU in Portland, celebrating. I finally had my last surgery related to cervical cancer. Shortly after that, we were matched with a surrogate, and our surrogate was pregnant with one child. So we thought the embryo ended up splitting, and we had healthy baby boys arrive in March 2021. Like I said, they'll be 5 in a couple days. Truly, again, the light of my life. Since then, a lot has been healed from the journey that I went through from cervical cancer, and our family was complete. So, as a result, we donated our embryos to another family in need who, who it happens to be the founder of the survivor organization, Tamika Felder and Rocky Campbell. They are proud parents to a 3-year-old who is a genetic sibling to our twin boys. So some kindness in all of this is I was so moved by our surrogate giving me the gift of becoming a mother. I wanted to pay it forward and give that gift to another. So that's kind of the fun story. There was a People magazine article that Ashley's going to link that was published actually just this week about our story if you're interested in hearing more about it. But I am coming up on time, so I'll rush through these next few slides, but I could talk about that all day long. Anyway, going to the next slide, cervical cancer impacted all aspects of my life. It impacted my career. I have a career in human resources. It taught me how to lead with empathy. You never know what someone is actually going through. It impacted my family and the ability to create one. Impacted my finances. Over here, my out-of-pocket expenses were over 20 grand just to get through cervical cancer treatment, even with good insurance, and $150,000 towards creating our family in out-of-pocket expenses for surrogacy. It impacted my social relationships, intimate relationships. My husband and I haven't been able to have regular intercourse in 9 years, so that's something that's still stuck with us. And of course, it impacted my health. I take charge of my health now. We'll move on to the next slide. So this next slide is really special to me. This is a picture of Survivor School. And in this photo, you can see these women come from all different backgrounds, all different demographics, truly from around the world, different geographies. They have a number of barriers, and truly, cervical cancer doesn't discriminate against any of that. Anyone can be impacted by cervical cancer, and these are the faces behind it. I share this because in this photo, there are 2 women that were standing there with me 2.5 years ago that are no longer with us. So it is I feel like my responsibility to share the work and hopefully end cervical cancer for the next generation in their honor. So I'm proud to be here today to do that. We'll go on to the next slide. I mentioned my approach to wellness and cancer prevention ever since. So I've taken an approach that blends Eastern and Western medicine together. I've got a chiropractor, a naturopath, a great primary care. I've got a health coach. I've got a gynecological oncologist who I got to see actually on Monday for my checkup. And I've got a great therapist, and that's just kind of all of the things that were required for me to move forward in the most meaningful way possible. On the next slide, I share 6 things I would tell my 20-year-old self. And, I would love to go through each and every one of these, but I think most importantly, my message is just listen to your body. I knew back in December 2015 when I was denying myself the simple luxury of wearing that great gift my husband got me for Christmas, that something was really wrong. I'm so grateful that I went into the doctor, despite it taking so long to finally getting diagnosed with cervical cancer. I knew something was wrong, and I'm glad I kept listening to that inner voice that I had to ensure that I'm here today and I could fulfill my dream of becoming a mom and spreading advocacy for those who can't. Um, so I guess just my last part that I wanted to share with you is the work that you do matters. Getting into those rural communities absolutely matters. Had I had any more barriers to finding out that I am getting diagnosed that I with cervical cancer, being a white female in a major city, at the time I was living in San Diego, I had access to great health care. But again, if I had any more barriers, I honestly don't know if I would be here today to be able to tell my story. So again, I'm so grateful for self-collection and the access that it provides to other women who may not normally have the access to get into a doctor's office. And excited to learn more about that today, and really grateful for all the great work that all of you do. And I know Ashley will share my contact information if anyone has any follow-up questions or comments. I look forward to connecting with you at a future date. Thank you.
Jenny, thank you so much. I really want to extend a heartfelt thank you to you for sharing such a powerful and personal story with our rural learning community. Your willingness to speak openly about your experience helps to ground this work, in real lives and real impact. And your story really reminds us exactly why we're working to increase HPV vaccinations and expanding access to cervical cancer screening in rural communities matters. So thank you so much. I'm really, truly grateful for your time, your courage, and your advocacy for speaking today. So thank you. You got lots of love in the chat as well. We are going to now transition and hear from Dr. Deanna Baptiste, who is an epidemiologist and Senior Director of Cancer Screening Guideline Development at the American Cancer Society. So Deanna is going to be talking us through our updated cervical cancer screening guidelines. Her full bio will be in the chat, and there'll be a way to connect with her as well. So Deanna, go ahead and take it away.
Good afternoon, everyone, and thank you for the opportunity to speak today. And it's following Ginny. That's a hard act to follow, but I will try to rise to the occasion. Thank you, Ginny, for sharing your story. It makes me more grateful that I have a career in this space where I can make a difference. My name is Dina Baptiste, and I'm a epidemiologist and as the Senior Director for Guideline Development at the American Cancer Society. And today I'll give you an overview of cervical cancer screening, including current disease burden, trends in uptake, and the recent updates we made to the ACS cancer screening recommendations. Next slide, please. I have no financial conflicts of interest. I'm an employee of the American Cancer Society, and I'm the person who manages and the methodologist for the development of cancer screening guidelines. Next slide, please. Our mission at ACS and our vision is very bold to end cancer as we know it for everyone. And cancer screening plays a critical role in achieving this vision because it enables early detection and prevention of cancer through identification and treatment. especially in the case of cervical cancer, which is preventable through the treatment of precancerous lesions. Next slide, please. So let's begin with some key statistics. According to ACS's recent estimates, we are expecting approximately 13,500 new cervical cancer cases and about just over 4,200 deaths from cervical cancer in 2016. Cervical cancer, again, I would like to emphasize, is one of the most preventable cancers, largely due to HPV vaccination, which has been around for quite some time now, screening, and of course, and treatment of precancerous lesion. However, despite these strategies, cervical cancer still occurs, and most often it occurs in, not all the time, but most often it occurs in individuals who have either never been screened, who are under screened, or do not receive appropriate follow-up after abnormal screening results. So while we have effective prevention tools, the challenge remains ensuring that we have equitable access to using these tools and that everyone get the message that utilization of these tools is important. Next slide, please. So quickly, just looking at the disease burden, this slide shows cervical cancer incidence and mortality by age. A key pattern that's important to note is that incidence begin to rise in the late 20s and early 30s. And rate peaks in about midlife, which is around the 30s and 40s. However, mortality continues to increase with age, and this reflects a very important epidemiologic reality, as older women are more likely to be diagnosed at later stages, which contributes to the higher mortality rates. And these patterns reinforces why consistent screening during midlife is essential to detect precancer before progression to invasive cancer. Next slide, please. This slide highlights incident trends by race and ethnicity on your right over several decades. So as you can see, while cervical cancer incidence has declined over time, partly due to screening, we still have some very important disparities that exist. American Indian and Alaska Native have the highest incidence rates. Hispanic and Black women also have experienced higher rates compared to white women. And Asian and Pacific Islander women tend to have somewhat lower rates. There are several factors that contributes to these differences, but a driver of these inequities is screening access, follow-up care, and of course, there are social determinants of health that we cannot rule out. And I also want to point your attention to right there, that blip at 2021, where we saw a sudden increase in rates from cervical cancer cases after decades of steady decline. And I will touch on that on future slides as to what we think might have resulted in that. Next slide, please. So here we see the trends in cervical cancer screening participation over time. And this, of course, also shows by race and ethnicity. Historically and currently, screening rates across groups have been relatively high. Please be mindful, though, that these are self-reported rates. These rates are based on self-reported data. In particular, screening participants tend to be lower among Hispanic and Asian population, and while rates are generally higher among white and Black women. So these, again, highlight the need for more targeted and culturally appropriate screening programs. Again, I want to note here, you know that screening, where we have that gap right there, that's around the time of the pandemic, and maybe even a little bit before in 2019, where we saw screening rates starting to decline across the board among all race and ethnic groups. And this translated to a spike in incidence rates. So that's very concerning. And why it's even still concerning is because the most recent data we have showed that we have not rebounded in screening, that the rates have not gone back to the pre-pandemic level. So that's something that we need to work on. Next slide. So looking at the most recent rates, again, this is from 2021, we see that about 76% of eligible women reported being up to date with cervical cancer screening according to ACS guidelines. And you should be mindful here that the reason I juxtapose both ACS and the U.S. Preventative Services Task Force is because our guideline states starting at age 25, and the task force recommends starting at age 21. Overall, about 80% of white women reported, these are self-reported data, reported that they're up to date with screening compared to about 76% of Black women and around 69% of Hispanic women and American Indian and Alaskan Native women. Next slide. Now, we're looking at screening by age, screening participant by age. Screening rates are generally highest among women in their 20s through their 40s. And of course, we think the reasoning for this is that that's a period of life when most women who are of childbearing age who wants to, whether because they want to have a family or they're starting a family, they usually more actively seeking gynecological care. So they're more likely to get screened because let's face it, in the US, we have an opportunistic screening program. We don't have a screening program that's targeted or population-based. However, screening participation begins to decline in older age group, particularly after age 50. This is concerning because it reflects the higher mortality rate that we see in older women, which is consistent with screening through midlife is essential to ensure individuals meet the criteria for safe exit later in life. Next slide. And of course, highlighting again disparities, particularly in the US where we have such variability in our healthcare access and who have insurance and who does not. We see that insurance coverage play a major role in participation in screening. About 80% of women with private insurance reported being up to date with screening, compared to only around 58% of uninsured women reported being up to date with screening. And these differences, again, highlight how financial and healthcare access also serve as a barrier and directly influence cancer prevention outcomes. Next slide. So really, the ACS issued revised recommendations for cervical cancer screening in 2020. And recently in 2025, updated recommendation. This slide compares the 2020 ACS guideline with our most recent update. The core recommendation remains similar, but an important update is the addition of HPV self-collection as a screening option. Important for you to note is that we still recommend a clinician collected HPV test every 5 years as the preferred screening for cervical cancer, and HPV self-collected sample every 3 years. Co-testing and cytology are still recommended. Cytology pap testing are still recommended as screening for women who do not have access to primary HPV testing. Next slide. So I want to speak real quickly on self-collection. HPV self-collection has received increasing attention in recent years. Recent research has shown that self-collection is feasible, acceptable to patient, and clinically viable. Self-collection also offers several advantages. It may reduce barriers related to pelvic exams. It may increase screening participation among under-screened population, and it may improve screening access in non-traditional healthcare setting. However, and I guess there are others here who may speak to this, that implementation into the clinical workflow and follow-up care is different, so that requires some consideration. And again, I just want to emphasize that our current recommendation for HPV testing on self-collection sample is for 3-year retesting or a 3-year interval for negative tests or normal tests. However, for a clinician collected sample, we recommend a 5-year interval for normal or negative test. Next slide. And so one question we get asked is, why didn't we include self-collection in 2020? And we stated in our guideline at that time, we referred to it as self-sampling, is that we recognize that studies showed feasibility, acceptability of self-collection. We recognize the growing body of evidence and the advantages that it has, and especially for increasing access. However, at the time, there was not a FDA-approved test on the market, and we did not have enough data to make a guideline for self-collection. Next slide. I should say we did not have the evidence to make a guideline recommendation to support self-collection. So what happened since then? Between 2024 and 2026, the FDA approved devices that allowed self-collection of vaginal samples for HPV testing. Currently, the FDA approval allows self-collection within the healthcare setting when the patient and the clinician can determine that a clinician collected sample is not feasible, or the patient would prefer not to. That decision can be made. And just to be clear, self-collection in a clinical setting does not mean that a clinician is in the room with the patient. It just means that the patient is collecting the sample in that clinical setting. It could be a primary care clinic, a gynecologist's office. I have heard that possibly in the future we may have this done in pharmacies, urgent care, or even mobile screening programs could employ this. There is currently one device on the market, which is the Teal wand, which is developed by Teal Health, that is approved by the FDA for at-home self-collection. At the time our guideline was released, I think it was available in about 12 states. And I need to check on this. I'm not sure how many states since they have expanded to, but that's the only at-home self-collection device that's currently available. A very important thing about self-collection that I want you to take note on this slide is that the devices that are used for self-collection, it is very important that they be paired with the appropriate assay. So there is some coordination that should be done between the clinical facility and the laboratory facility to make sure that whatever the device that the patient is using for self-collection, that the test has been done with the appropriate assay to match that device according to the FDA approved platform for these devices. Next slide. Again, I want to emphasize that it is important to understand the difference between clinician-collected HPV testing and self-collected HPV testing. The main difference is that a clinician-collected sample, that sample is taken directly from the cervix during a speculum exam, and it supports HPV testing. It supports Pap cytology or the Pap test, and it supports additional triage tests if that test, the initial screening test, is positive. Self-collection samples, on the other hand, are vaginal samples. They do not require a speculum exam or for the clinician to be involved in the collection of that sample. Because of this difference, positive self-collected samples results often require a follow-up clinical exam for further evaluation. So while self-collection improve access, it's a different clinical workflow and follow-up process, and this should be communicated to patients who choose self-collection or for whom self-collection is their best option for screening at this time. Next sample, I'm sorry, next slide. So again, this table highlights the practical differences between cervical and vaginal sample collection. Again, it's who collects the sample. One is the clinician, the other is the patient. Whether a speculum exam is required, and that is a big factor for a lot of patients and can be, for some patients, can be a barrier to screening. And whether multiple tests can be performed on the same specimen. Cervical samples allow HPV testing, cytology, and dual stain testing, while vaginal samples are typically used only for HPV testing. Another important point is that about for guest clinicians and maybe to even convey this to patients to realize is that about 60% of HPV positive patients will still need a follow-up test. There's some patients who are positive and may not need a follow-up test, but about 60% of patients will need a follow-up test. So that will require a return for a clinical exam. Next slide. So why self-collection? Self-collection is important because half of cervical cancer cases, about half, maybe more, occur in individuals who are under screened or never screened. And self-collection can help address several barriers, including patients who are averse to having a pelvic exam or who experience discomfort in getting a pelvic exam. Then there's the issue of lack of access to gynecologic care. There are geographic barriers depending on where people live and how many clinicians are within that area. And then there's other structural barriers such as time, transportation, and also we have very good data from countries such as Australia who have successfully incorporated self-collection to reach underserved or under-screened population to show that this is highly effective. So overall, we have evidence that shows that high patient acceptability and effective implementation in other countries where this can be very effective. Next slide. It's important to note that not everyone is eligible for HPV self-collection. Individuals who may be eligible include those who prefer to avoid a speculum exam, who do not have access to clinician-collected samples. Now, a clinician to collect a sample. Now, it should be noted that if there are certain things that patients should be communicated to patients, such as if you're menstruating, you should not do self-collection. If you have recently used vaginal products, then you should also not do self-collection. Persons who are not eligible are include those who are at higher risk for developing cervical cancer, such as persons who have HIV infection, history of DES exposure in utero, and if you have symptoms for abnormal bleeding or abnormal vaginal discharge, then you may need to this may not be the preferred method of screening. It's not recommended. Also, if individuals who are choosing screening at age 21 to 24 should be screened with cytology or the pap test, which require a clinician-collected sample from the cervix. Next slide. So an important but often overlooked issue is cervical cancer in older women. However, approximately 20 to 25% of cervical cancer cases occur in women aged 65 years and older. Older women also tend to have a higher mortality rates, primarily due to later stage diagnosis. Next slide. This slide illustrates that although incidence decline after midlife, as you can see there between women in their mid-40s to late 50s, that cervical cancer still occur after age 65, and there's a jump in women over the age of 70. So this pattern reflects a gap in screening earlier in life. In many cases, cancer diagnosed later in life are the result of precancerous lesions that were never detected or treated decades earlier. Next slide. Why rates remain high in older women? There are several factors. Cervical cancer rates remaining higher in older women. The first is inadequate screening before screening exit. Guideline recommend stopping screening at age 65 only if adequate prior screening has occurred. However, many studies show that many women reaching age 65 do not meet these criteria. Another factor is declining screening participation after menopause, which may be due to fewer gynecological visits, misconceptions that screening is no longer necessary, and inconsistent provider recommendation, because we know that one of the largest influence for getting screened is a provider recommendation. Next slide. Additional factors also include that contribute to cancer risk in older women include long natural history of HPV. Cervical cancer can take 10 to 20 years to develop after persistent HPV infection, meaning infections that occurred earlier in life may lead to cancer decades later. Second is the accumulated disparity in access to healthcare can increase risk, particularly among women with limited healthcare access and some racial ethnic minority populations. So overall, cervical cancer diagnosed later in life often reflect missed opportunities for screening in midlife or earlier in adulthood. Next slide. So we often get asked, well, why recommend stopping screening after 65? And the main reason is that we have data that shows that there is a very low risk of developing cervical cancer after the age of 65 in women who have been adequately screened. Not to say that there are cases where that it will not occur, but there is very low risk, and screening recommendations are based on a balance of benefits and harms. Individuals who can exit screening, our recommendation has been simplified from what we recommended in 2020, where we said, 25 years of no abnormal tests and so on and so forth. Now it's simplified. We recommend 2 consecutive negative HPV-based tests or 3 consecutive negative cytology tests, with the most recent test or the last test should be at least age 85. So, if you had why is it the age? So if you had if you're doing self-collected HPV testing and you had a test at age 63 or 64, no, you should not exit at 65. You should get another test 3 years after to exit. So the last test should be at least age 65 or older. In this population, the future risk of cervical cancer is very low, and making the harm-benefit balance for continuing screening not very favorable. Next slide. So another reason for stopping screening after adequate testing is that the potential harms increases with age. Continued screening beyond age 65 can lead to false positives, negative, unnecessary colposcopies, biopsies, and procedure-related complications. We have modeling studies that show that continuing screening after 65 is inadequately screened women provides minimal benefit. The emphasis there is adequately screened women, but significantly increases the number of tests and procedures. Therefore, when adequate prior screening has occurred, the harms of continued screening may outweigh the benefits in continuing to screen women. Next slide. Finally, cervical cancer is one of the most preventable cancers. Prevention relies on two powerful tools that we now have. HPV vaccination, which prevents infection with high risk HPV types, and we have screening, which detects precancerous lesions before cancer develops. With widespread vaccination and effective and screening, and continued efforts to address disparities in and access to care, we have the potential to dramatically reduce cervical cancer incidence and mortality. And recently, Australia announced that they're well on their way to achieving this goal. So I think it's possible for us to do the same. And that is next slide. That is all I have today. I will stick around for the panel discussion to take questions. Thank you so much for your time.
Thank you, Dr. Baptiste. I really appreciate it. If you just want to go to the next slide, Hannah. I'm going to quickly, in the interest of time, introduce the rest of the panelists, but really want to allow all of them to be able to share their experience and expertise. So besides Dr. Baptiste joining, we also have Dr. Halley, Dr. Pugh, and Dr. Soltani. My colleague Brianna is going to add all of their information into the chat so you guys can read their full bios, also be linked to them and connect with them. And then we are going to go ahead and get started with our conversation, just so I can allow everyone the time and energy. So, Dr. Halley, how do you envision the updated cervical cancer screening guidelines shaping care delivery and access in rural communities?
I actually practice in a suburban community, so I may not be the best person to answer that one. But I think that rural communities, even more than suburban communities, have more needs because it's harder for people to get into care, especially if the home version becomes available. That will be a really good option. But let me defer on that question to someone who practices in a rural area.
Perfect. Dr. Pugh, I think you practice at least in a rural state. Do you want to share your thoughts on how these updated guidelines will affect rural communities?
Well, I can to some extent. Thank you for having us on today. Went fantastic. I answered the person about the dual staining. Bad news is we don't have dual staining with LabCorp right now. UAB does that, but we don't. Wish we did. So in the rural areas, we actually practice in 66 counties. I'm sorry, 67 counties. Alabama has 67 counties. A lot of those are rural. I cover 65 of those counties. Now, Jefferson County and Mobile County, which is Birmingham and Mobile, they're not really part of our system as far as what we do for screening. The problem we have with what we're trying to do with the new guidelines and everything in Alabama is that to do the self collection, you have to be an average risk person, and we don't have average risk persons in Alabama because most of Alabama is rural. And so what we changed that basically, and with what we did with our program to increase our screening and by doing, offering more colposcopy in the health departments across the state. So we have more than 65 health departments. Some counties have two. And so we trained our cervical colposcopists, the nurse practitioners, to go out and do the colposcopy. Now, I wish that we could do the self collection HPV testing we have no way to follow up with that right now here in Alabama. So we talked with that with our last meeting with Dr. Huh at UAB on our with our ABC program, Alabama Breast and Cervical Cancer Detection Program, and that was an issue. I think it was the teal people that were looking at trying to get, instilled here in Alabama, but we could not do that right now because we have no way to follow up, with those patients. They don't have local follow up right now, and the labs are not, ready to run those tests. Hopefully that's going to change, but right now we're doing what we do is, going out to the rural areas to take a lot of the barriers away. That was our biggest issue here in Alabama on healthcare. A lot of our people in Alabama don't have a lot of money. They don't have travel. They don't have transportation, and they don't have child care. And so what we did is we trained nurse practitioners to do mobile colposcopy, to go to them and do the colposcopy. And we use a mobile colposcope. It's called an Eva Pro, and it looks sort of like this right here, a cell phone, but it's a cell phone that actually has a camera on it, and they carry that in a bag with them along with all their equipment, with their Tischler and their ECC forceps and stuff. And they go out and they do the colposcopies, and then we have a really strict QA program here. They send me a copy of the reports once they get the pathology back, and I okay their plan of care with that. And then once that's done, they sign it to the chart, and then I sign the chart. So I see it twice. I do a QA on 100% of our colposcopies done by our nurse practitioners. We currently have 8 nurse practitioners credentialed to do this, and we also have, I think, 7 more in training right now. So that's how we have, adjusted our thing. We started off with this program in 2019, the end of 2018, the first part of 2019 with Dr. Grace Thomas, my predecessor, started the program. And they were averaging about 215 to 230 a year colposcopies. I can be happy to tell you that last year we did 1,021 colposcopies in that fiscal year. This year we're on target to do more than that, actually. Another good news, and you can look this up, that Alabama used to be ranked number 5 for cervical cancer prevalence. We just dropped to number 6. So, and I
Great.
think it's largely effect from this colposcopy program that we have.
Thank you, Dr. Pugh. I really appreciate you sharing about that. Dr. Soltani, I would love to hear from you because I know you have a self-collection program in place in your community health center. I guess if there was a rural clinic that wanted to begin exploring self-collection, what foundational steps would they need to take to create a smooth workflow?
Thank you so much for inviting. And I'll say, a disclaimer, I'm an internal medicine doctor. I'm a primary care doc. I mean, I don't consider myself women's health. And I think until all of us can recognize that we cannot depend on a network of women's health specialists to get cervical cancer screening in the rearview mirror, I think we're going to continue to fail. And, there was a big study in JAMA Network Open last year that showed that the largest percentage of unscreened people seek care at FQHCs. So it's really our safety net centers and health departments that really need to carry the water on cervical screening. And that means we cannot wait for everybody to wake up in the morning and say, oh, it's time for me to go in for my pap smear today. We need to get them at any opportunity, no matter what people are coming in for, completely unrelated things. If they come into any of our health systems as safety net providers, we absolutely need to catch them right then. And that is the true benefit of self-collect, that, I can spend, I have 15 minutes to take care of uncontrolled diabetes and depression, substance use disorder, all the things. And, minute 14, I can say, here's the self-collect. See this tiny little Q-tip. This is what a flock swab looks like. It's small, it's not scary, and I can say, here's my, office restroom. Go in there and do your self-collect today, and let's get you at least on the road to screening. So, I think in this country we've allowed perfect to be the enemy of the good. Every day our patients suffer from that, and I think that the more that we can simplify guidelines and remove barriers and just recognize that, I may not have time to calculate your entire lifetime risk of cervical cancer to decide, oh, it needs to be this versus that. If you are overdue and I have no other practical way of getting you screened, I'm going to hand you the self-collect. So I think once you recognize that in a very busy health system, a safety net type center, the first step is to grab the necks of your contract labs and say, you must bring a self-collect option on board and do not take no for an answer. Step two is to negotiate the rates because, once they get we use Roche Cobas, we've asked our contract labs, so now LabCorp and Sonora in our state both have the Roche Cobas system. Um, and they kind of, I don't know how they determined pricing, but the initial price they came up with did not seem reasonable. So again, shipping away and making sure that the price is reasonable for your practice and for your patients. And then yes, we always offer it during a clinician visit, but we also set up a nurse protocol, some standing orders so that, again, when patients are coming in for vaccines or walking in for any other reason, the nurses are empowered to identify that they have a cervical screening gap and talk to them at that point about doing a self-collect during that nurse visit. And I think all of those things really help. That then allowed us to do some outreach, essentially look at all of our lists of patients who were overdue for screening and use all of our outreach mechanisms to allow people to walk in so they're not having to take days off work, try to find childcare, trying to do all the jumping through hoops to get in front of a clinician. They can walk in for a nurse visit, and that has really helped. So in our first 6 months, we screened over 750 people with self-collect. In that group, our positive or abnormal rate was about 9%. Not all of those then needed to go to Colpo. Many of them, they could go to PAP as well. So really just brought a huge number of people into screening who had not been previously screened. So we've had a great experience so far, and I'm happy to share any of those protocols with people if they want to contact me.
Perfect. Thank you so much, Dr. Soltani. Dr. Halley, would love to hear any lessons you've learned around implementation of self-collection.
We did a really comprehensive rollout for our organization. We started with being part of the Step 2 trial. So we had 3 clinics that started. We'd planned for a year up ahead of that. But the main things that I think were helpful to us is we did training for providers and a separate one for our medical assistants. We had an Epic build that allowed we had patient-oriented information sheet and instruction sheet that are up in the bathrooms and that our medical assistants give to patients who are eligible. So we have a whole huddle plan where provider and the MA talk, this person's eligible for HPV self-collect. MA gives them the handout, says there are 2 options now. Read about this while you're waiting for your provider. And then I go in and talk to them further about that. People are very, very interested in the HPV self-collect option. And I totally agree with you, Dr. Soltani, that I think there's a balance between maybe one test is sort of preferred and has some benefits to it. However, to me, what's preferred is what I can do right then and there, because I don't know if that patient's coming back. They might say they are, and they might not be. And so, to me, that's the balance that I work off of. And I'm doing diabetes, hypertension, asthma, and I can get them screened for cervical cancer. And then we also did an FAQ for our providers that just answered basically any of the questions that were coming up for them. We had smart phrases. And so just made it as easy as possible. And we've just been really successful. Providers love it, patients love it.
Perfect. Thank you so
We
much.
recommend screening options, but at the end of the day, the best screening test is the one that can get done.
Correct. Correct. Thank you so much. I would love to hear from all of you. What is your favorite patient or professional resource around cervical cancer screening. So we got a couple of minutes. If each of you could just share quickly, would love to get these into the resource roundup. So I'll start with Dr. Baptiste, and then we'll go Dr. Soltani and Dr. Hallie.
Well, as I'm in a different space here at the ACS, but my best resource, I would say, is the HPV and cervical cancer roundtable.
Perfect.
I go
Yes.
to them for the practical field because sometimes, my end research and just looking at papers and what's experienced in the field is completely different. So I would say tap into the National HPV and cervical cancer roundtable.
Perfect. Thank you. That's a great one. And I did add the National Roundtable for Cervical Cancer Resource Center onto the resource roundup. Dr. Soltani and the Dr. Hallie.
Sorry, I agree. I think the roundtables have really great patient-facing and clinician-facing resources, including slide sets. So if you just need, a small set of slides to be able to convince your clinicians, I think that's a great place to go. There's also HRSA has a toolkit that's basically a whole binder of a collection of both patient and clinical resources, including kind of workflow steps on how to get some of these up and running. And I'll find that resource and I'll put it in the chat in just a second as well.
Perfect. That would be great. Thank you so much. And Dr. Hallie, what would be your go-to?
I agree with all of what's been said. I don't have anything to add to that.
Perfect. And then just to kind of end the conversation, I guess, Dr. Haley, I'd love to hear, I guess, big picture, where do you see cervical cancer screening in the next 10 years? Just thinking about the
Um,
innovative ideas.
well, I certainly think and hope that home testing is going to be the wave of the future. Kaiser's already been doing that for many years. They have their own lab and are able to do that. And it's like fit testing that you can just mail out. People can do it. And so I think that's probably going to be the future. Hopefully, we'll have less cases in general because of vaccines too.
Yep, yep, vaccines.
Perfect. Well, I want to thank you all for joining today's panel. I know this was very quick and fast, but I really appreciate you all sharing your expertise and your stories and your experience. I know, Dr. Haley, I saw that you wrote some things into the chat, and I will make sure that we document it and share it out. But I really want to thank you all again for being a part of today's discussion. And we are going to go ahead and wrap up this session because I know we are over time. But I'm really grateful that my colleague, Brianna, was able to put everything that we were going to share towards the end in the chat. So we are good there. Hannah, if you just want to pull up our thank you slide.
There were a couple questions in the chat that I also responded to, so hope that helps.
Perfect. Thank you so much, Dr. Baptiste. I really appreciate that.
I responded to a couple things also in the chat.
Perfect. Thank you so much, Gary. I really appreciate it as well.
No problem.
All right, so we are just gonna wrap up here quickly. So I want to thank you all for joining today's session. We really appreciate your time, insight, and commitment to this work. We look forward to seeing you again on April 8th for our next session, where we'll be talking about the shift in adolescent vaccines. And so this will be our first session around HPV vaccination. But until then, I want to thank you all for everything you do to support rural communities and look forward to seeing you on April 8th.
Thank you.